Good evening. I am Brother Dr. Jeffrey Sterling, the Surgeon General for Alpha Phi Alpha Fraternity Incorporated, and on behalf of our General President, Brother Lucian Metellus, and our Board of Directors, and the Deputy Surgeon General, it is an absolute pleasure to be here with you today on this pretty important and timely topic about Medicaid policy and the future of Black men. We not only will be speaking to Black men, by the way, but Black families and all the global American community. But first of all, I just want you guys to understand what it is we're trying to accomplish here. In my work over the decades around the world, one thing that's always been notable about the United States is that there is more than enough money in the system. And I mean that to say that it is somewhat inexcusable, it's quite inexcusable to be producing the type of healthcare outcomes that we do. That's a different conversation that I'll have with you down the road. But the point to be made here is that if indeed there are governmental efforts to make healthcare more efficient or to do anything to healthcare, the conversation really does need to start with the combination of Medicare and Medicaid. In 2023, the total Medicaid spending in the United States totaled about $872 billion, dollars, and the federal government paid about 70% of that amount, just over $600 billion. Dollars. You may have heard ruminations that the government is looking to cut about $800 billion dollars in healthcare spend. The reasons behind that perhaps will be discussed in the panel. But the point to be made is that let's just keep an eye on whether or not efficiencies are being made that improve and or maintain the level of quality and services that currently exist, if not seek to improve them, instead of slashing services that have already for a system that's already producing suboptimal healthcare outcomes. Keep an eye on that, and we'll talk about that a little bit later in the program. At this point, I'd like to introduce our new Deputy Surgeon General for Healthcare Disparities, Brother Dr. Okienya, who is a seasoned scholar, activist, health policy expert, published author, and strategist with deep expertise in health equity, public policy, government relations, and advocacy. Brother Inya actually serves as the Associate Vice President for Federal Government Relations at the National Multiple Sclerosis Society. He is also the founder and CEO of Inya Strategies, which is a public policy advocacy consulting firm that's dedicated to reducing healthcare disparities, eliminating healthcare inequities, and promoting health justice. Of course, he's a life member of Alpha Phi Alpha, and he is a part of the Pi Epsilon Lambda chapter in Prince George's County, Maryland, my old stomping ground. It's good to be with you, brother. Have a great show. I look forward to talking to you along the way and on the back end.
Absolutely. Thank you so much, Brother Sterling. Yes, good evening. I'm looking forward to this very timely and enriching conversation this evening. And to set the context for this very important conversation, I'm going to just kind of lay the groundwork for what Medicaid is, and then I'll have the panelists to weigh in to give their thoughts and expertise. I do want to thank our fraternity for hosting this event, and I look forward to future conversations in this space. And so today's conversation is about solutions. Medicaid is the nation's largest public health program covering over 72 million people, including a significant number of Black men. Yet, despite its broad reach, Black men still experience disproportionate health disparities, being 30% more likely to be uninsured and and 25% less likely to have a regular healthcare provider compared to their white counterparts. Structural barriers from economic instability to administrative hurdles continue to limit access to Medicaid and its life-saving services. At the same time, Medicaid is at the center of ongoing national policy debates. Proposals for cuts to the budget have raised concerns about access and equity, yet Medicaid remains one of the most widely supported programs across the political spectrum. This reality underscores both the challenges and opportunities in strengthening Medicaid's role in Black men's health. Um, I'll also note briefly that this Sunday marks the 15th year anniversary of the signing of the Affordable Care Act by President Barack Obama. And as a personal point of privilege, I'll share that my doctoral study was the first of its kind to examine the Affordable Care Act and its impact on access to care for Black men. And so to help us navigate these critical issues, we are honored to have an esteemed panel of experts. I'm going to call up Brother Dr. Joseph Benitez, who is an assistant professor at the University of Kentucky's Martin School of Public Policy and Administration, and a leading expert in the Medicaid space. I'll also call up Brother Marvin Figueroa, who serves as a vice president at BGR's Health and Life Science Practice. He's a former senior HHS official, a former chief of staff to Senator Alfonso Butler from California, and a faculty member at the Meharry Medical College Global School of Public Health. And then also Brother Dr. Truman Warren, who is a pharmacist and a community organizer based in Texas. And so this conversation is about more than policy. It's about protecting and advocating for the health and well-being of Black men and boys across the country. So I encourage each of you in our audience to engage, ask questions, and think about the role that we play in shaping policies that affect our communities. And so I'm going to open up the floor because it's important to lay the groundwork for this conversation and ask Brother Benitez if you can explain what Medicaid is and why it is an essential program for Black men's health. And then what are some of the unique barriers that Black men face when trying to access Medicaid?
Sure. So I would just like to thank the fraternity for allowing this space. And I would also like to thank you, Brother Dr. Enya, for coordinating this and even reaching out to me to participate and contribute to this panel. So first off, you're exactly right. Medicaid is one of the largest health insurance programs in the United States, comparable in size only to Medicare. Medicaid is the public health insurance program for low-income Americans, of which Black households, especially Black men, tend to be overrepresented in terms of poverty and in terms of the income gap and even the wealth gap, but underrepresented with respect to eligibility. So people pursuing Medicaid are largely at the discretion of the rules outlined by their states of residence. And as you pointed out, with the significance of the anniversary of the signing of the Affordable Care Act, that was a major step in addressing many of the coverage disparities in the United States, of which, because Black families tended to be overrepresented in terms of poverty and overrepresented in terms of not having coverage prior to the ACA, were more likely to benefit from the coverage expansions from the ACA, of which expanding Medicaid eligibility to a larger share of low-income Americans substantially helped Black families in major ways, both in terms of improving their access to healthcare, but also addressing a lot of other social needs, such as being financially constrained or experiencing housing insecurity and even food insufficiency and not having enough food to eat, or even difficulty affording your daily basic needs. Because healthcare, as we know, is expensive. And it's even more expensive for people who have to go without or have to make a decision of, do I eat this week or do I go to the doctor? Of which, for many people, that is an unfortunate decision to ever have to go through. But because of Medicaid expansion, it alleviated a lot of that fiscal constraint on households to make those types of decisions. Where we stand now with Medicaid expansion, as the states with the highest concentration of Black families and especially Black men have yet to expand Medicaid, so including states like Georgia, South Carolina, Alabama, and Mississippi, so to speak, and even by extension, Florida and Texas have yet to expand. Where we stand now with Medicaid expansion and even just Medicaid in general is going to be up in the air, because with a lot of discussion around these proposed tax cuts that are likely to come and become an issue in the ongoing months around policy debates. Is where is the money going to come to finance? And often, Medicaid has become a focus of these discussions. Of we know the about the cost of Medicaid annually comes to around $880 billion in 2023, I want to say. And then the tax cuts are proposed to be valued at close to the same value. So even though Medicaid is not named in particular, um, many people are making the connection that they're going to be financed through cutting Medicaid, whether that's cutting eligibility, cutting benefits, and cutting potentially what Medicaid even pays for. And as mentioned earlier, Medicaid covers about 72 million people, of which enrollment grew during the COVID-19 pandemic. Uh, Many of which were families that were adversely affected by job loss sustained during the early part of the COVID-19 public health emergency. Many are unwinding and are getting off of Medicaid and moving to other health insurance plans, but many still could be on Medicaid because they're still considered low income or income eligible for Medicaid. Um, and I look forward to hearing from the other panelists who are more on the ground than I would say I am as a researcher. So I look forward to hearing both what you hear about in policy talks, but also what you hear in the as a as a healthcare provider. So I look forward to hearing the other more on the ground and more grounded perspectives.
Yes, yes, sure. And so, with that, I'll open up the floor to Brother Martin Figueroa and Brother Warren to give their perspective on this first question. Is what kind of, based upon your own experience and your vantage point, what are some of the unique barriers that Black men face when trying to access Medicaid?
I'm happy to jump in here, good brother. Just want to say it's an honor to be in the house of Alpha with all of y'all, and I'm excited to engage in this conversation. There's a couple of things that I want to point out there. Brother Benitez touched on a lot of these points. I think sometimes people underestimate or undervalue how important Medicaid is to the entire system. Right? Medicaid pays for primary and acute medical services. It also pays for long-term care services and support. So think about nursing homes. Medicaid also provides services to the most vulnerable, right? So pregnant women, individuals with disability, and people age 65 and older. That's Medicaid. Medicaid is the system that pays for those individuals to get the necessary care. And I think people don't really fully grasp that. Brother Benitez put the number out there on 72 million Americans depend on Medicaid. That is 23% of the U.S. population. It's also 41% of all births are paid through Medicaid, right? And so Medicaid is an essential component and is a cornerstone of our healthcare system. And when it comes to the barriers that Black men face when it comes to Medicaid, you name it, right? It's everything from bureaucratic red tape, complex renewal processes, and eligibility restrictions. They say to Black men, I know you want to be healthy, but this is not the way that you are going to achieve that health. And so when one considers how states have approached this, I was in Virginia for a long time as deputy secretary, and we tore down a lot of those barriers, but those barriers have been there since Jim Crow and before, right? And the goal is, again and again, to ensure that some people are healthy and some people are kept in the periphery of health, because we know what that will mean for folks to actually get the healthcare services that they need.
Awesome. Thank you. To our brother, Dr. Warren, please chime in here with your insights.
Good afternoon, brothers. It's great to be in the house. It's definitely great to thank you for this opportunity. Like I would like to echo the sentiments of the brothers that spoke before me. As a practicing pharmacist, and being on the first end, being on the front lines of seeing how Medicaid affects, especially the Black male the black men with Medicaid. Many of us, when it comes to the pharmacy, I see them not being able to access their health care that they need because of they either they haven't they have don't have the access to Medicaid, or they haven't signed up for Medicaid, and they qualify for it. They haven't been educated on the benefits of Medicaid, the benefits of utilizing that program, and they feel like it's only for women and children. So I oftentimes try to educate them about signing up for those programs with the Health and Human Service Department here in Texas and the local department to educate them, so they'll be able to utilize a service, because it not only pays for their medication, preventable healthcare treatment of the diseases that the disease states that can be prevented, that can prevent them from coming to the pharmacy every month, prevent them from having illnesses that can be, especially like cardiovascular disease. So cardiovascular, colon cancer, prostate cancer, things that affect the black male as much as more than it affects their white counterparts, lung cancer. So things of that nature. If they have Medicaid, they have those services that can prevent. They have those benefits. They can use those use those benefits to allow them to go see their primary care physician more, and more than likely they can prevent those conditions from happening. So that if they're educated about those things, that because most of the time they're not educated about those things because they don't have the resources, and they're not understanding that these things are available for them. So that's one of the things that we often see us when we're on the front line, that they don't even know that they're eligible for Medicaid. I know some states there are budget cuts, but some states they do fit the requirements, but unfortunately they're not educated about those things, and the social workers, care caseworkers, they're not educating them about the needs and the benefits of having Medicaid and Medicare.
You know, that's a fantastic point, because what you're getting at is, and this is what each of you have spoken to, is a social drivers of health framework, right? And so when you're talking about health, and I say all the time, like, your health is your wealth, and you'll find that um, income, education, housing, food, um, employment, like, all of those factors are what are framed as the social drivers of health, um, which impact health outcomes. And so I always try to connect the dots with all of the facets of the ecosystem, to at least ensure that we are meeting people and where they are. And before I shift gears into kind of a more solutions part of the conversation, I'm going to kick a question to our brother Figueroa. From your vantage point, working in policy, right, as a staffer, um, and your deep experience and expertise in the Medicaid space, um, we know that Medicaid is being targeted for budget cuts, and it is currently part of this debate whereby $880 billion have the potential to be cut from Medicaid to pay for tax cuts for the rich and wealthy, right? And so, can you talk a little bit about what activists can do, what policymakers can do, advocates can do to protect and strengthen Medicaid, especially as it relates to Black men?
There's a lot to that question, good brother. Look, I think that the current debate right now is focused, just as was mentioned before, in trying to find ways to fund these tax cuts, as you mentioned. And one of the ways that's being discussed is Medicaid, right? The president has said we're not going to touch Medicare, Social Security, and then at one point he did also mention we're not going to touch Medicaid, but we're going to go after what he calls waste, fraud, and abuse.
Yep.
And the reality is that they are talking about ways to finance the Medicaid program, and rather than sidestep the conversation by talking a lot about the minutia of how some states fund their program, what I can say is when folks mention that they won't impact direct services, that might be true for today, but it won't be true about tomorrow. Because a lot of the ways that you finance a program ultimately decides what are the services and supports that a state actually is able to render its people, its constituents. So what does that mean for us, right? I think for us, it means, especially when it comes to Black males, we have to be vocal about the ways that this program benefits our community, right? Whether it is a gentleman who is benefited from substance use disorder and is low income. That is Medicaid that is paying for mental health and substance use disorder. If it's preventative care and that person meets the eligibility requirements on the Medicaid, that is Medicaid that is paying to make sure that that brother has the screening that he needs to be able to catch that cancer early so that it won't kill the brother, right? Whether it's ensuring that there are ways that a woman doesn't die or a wife doesn't die during childbirth. That is, again, Medicaid that is providing those services, right? So one, we have to educate ourselves as to what Medicaid does. I think the issue with Medicaid is that Medicaid is called something different in every state, right? Because it's a federal and state partnership, in California is Medi-Cal, for example. We have a different name in Virginia. Different names don't change the subject. It is still the same thing. And so making sure that you know what Medicaid does and doesn't, making sure that you know your local officials who are engaging in this conversation, ensuring that you know your congressperson as well, because even in states where Medicaid hasn't been expanded, Medicaid will change drastically if these cuts go through, right? So everyone is impacted. If you have a parent that needs a nursing home, Medicaid is going to be the system that they use to be able to fund that, right? So whether it's birth or it's end of life or everything in between, Medicaid has a role, and we have to be vocal about what it will mean for our lives if Medicaid was to go away.
Absolutely. I want to have Brother Dr. Benitez to weigh in as well on this question. You are at a school of public policy, and so would love to hear your thoughts, kind of based upon where you see the debate might go, how you see us as activists, as advocates, as voters and constituents. What are your thoughts on the ways in which, from your point, how can we ensure that we can continue to better educate our communities and look to shift the narrative and drive the narrative to support Black and brown people writ large, but definitely Black men?
Sure. Okay. So to echo from Brother Figueroa, recognizing all the things that Medicaid does and thinking about all the things that it does for the broader healthcare system. Because it's not just about, even though these are people that are benefiting from Medicaid directly, local healthcare systems are also being stabilized and being financially viable because of Medicaid dollars. Even separate from direct payments that say hospitals might receive as a safety net hospital and through disproportionate share hospital dollars that they might receive for serving lower income communities. The coverage gains among lower income communities translate into increased revenues for hospitals, particularly hospitals that might otherwise be in the red. One of the things that's it's been very important for stabilizing healthcare systems across the states that have expanded, but expanding Medicaid led to reductions in hospital closures and improvements in the financial viability of many hospitals that would be considered safety net hospitals or dish dollar dependent. So understanding that there's some spill up effects from Medicaid coverage that extend to beyond just the people benefiting from Medicaid directly, having a stable health insurance or covered base means tangible benefits for other people. So even people that would not benefit from Medicaid directly. Some of the things that we can think about for advocates of what they can do, become aware of data sources and that they can use to communicate their arguments or communicate their discussions around Medicaid with stakeholders and key personnel that would make decisions or need to be informed around Medicaid. And as I said, with representatives and officials being sensitive to the ears and the voices of their constituents. One data source that I found particularly useful, produced by the Urban Institute maybe within the past week or so, was by congressional district, the number of people projected to lose Medicaid if certain cuts were to go forward. So becoming aware of different types of data sources that drive home who is actually going to be affected and who will likely be concerned. I think that is one thing that would help drive home to potentially decision makers, whether they're in Congress or your state legislatures, around Medicaid cuts and any changes to Medicaid.
Sure. I want to come back to a point that came up earlier, Brother Figueroa, and I want to get your take as well as Brother Dr. Benitez. We're talking about fraud, waste, and abuse, right? Fraud, waste, and abuse, and I'm using that intentionally in quotes because those that lean right like to use that phrase as kind of smoke and mirrors, or just like as a way to justify these cuts. And what I have found is that where a majority of the fraud, waste, and abuse comes from is actually not from the recipients of Medicaid. It's actually from providers and from brokers of insurance and so but what I also found is that it has been very challenging for the general public and just in general to be able to identify specifically what constitutes and measure fraud, waste, and abuse. There's a lack of transparency from what I found about, kind of what those terms mean. But my point is that a certain segment of our elected officials are doing a fantastic job, frankly, of messaging out the fraud, waste, and abuse argument as a way to justify cutting Medicaid that actually is helping the populations that we have discussed here. And so I'll also add another phrase, and I would love your thoughts in terms of what you know about what it would mean for us as Black men, is work requirements, right? So what are work requirements, and how is that ideology or that approach to justifying cutting Medicaid adversely impacting Black men? And open the floor to, go ahead.
Yeah. Dr. Benitez, you want to get in there?
Sure. Okay. So to go ahead and I guess I'll work backwards, starting with work requirements. So work requirements are this idea of, so for many people that are advocates of work requirements, it's a way of showing that you have some quote unquote skin in the game, that you have that you are engaged and you're not quote unquote being wasteful to society. Fact of the matter is, across everyone enrolled in Medicaid, 64% of people on Medicaid, or at least in the working age population, if we're thinking about age 18 to 64, are employed at least part-time. And that's something that we know empirically. Now, then if we were to separate the people out who should not be considered in the work requirements discussion, so people that have a disability, or are being a caretaker to someone else. So these are people that should not be, that are not to be considered in the work requirements, based on how the discussions have gone. But what work requirements mean? There is the activity of proving that you are either working for pay, you are engaged in, say, at least 20 hours of community service on a weekly basis in some states, or 80 hours per month averaged out over across each week, or that you are in school. I believe in some states are including school as a schooling, higher ed as a way of being community engaged. But it's less about the that you're actually doing it, but that additional red tape of proving that you're engaged. When Arkansas implemented work requirements just a few years ago, many of the people that were disenrolled were indeed working. Many thought that they should have been exempt from the work requirements implemented by Arkansas. And then there was also a sizable share that had no idea that work requirements were even implemented. So they weren't aware that they were being subjected to a policy change in their eligibility determination. So work requirements are increasingly discussed. What they do is they do lead to reductions in Medicaid enrollment, which fewer people on Medicaid would lower Medicaid expenses. That's exactly how the math would work out. But then the process of proving you're eligible and maintaining your eligibility status becomes harder for households to do, particularly households that might have limited time to navigate however the system is developed by their state, because all states do Medicaid programs differently, as was mentioned earlier. Every state's Medicaid program is independent of another. So we have 51 states, including the District of Columbia. So that means we have 51 semi-autonomous Medicaid programs that could do something very different around how they redetermine eligibility for their enrollees. Now, to kind of go back to your question about fraud and abuse, it is often very, and not to say that, and there is fraud in Medicaid, but as you mentioned earlier, it's usually on the supplier side. So it's usually what we know in the literature, where a lot of the Medicaid quote unquote fraud has occurred most frequently, is in the long-term care and even the skilled nursing facility setting, as opposed to enrollees themselves either using or misusing Medicaid. Studies have been done to kind of figure that out, but the magnitudes have been comparatively small if we were to think about fraud or people individuals themselves misusing Medicaid for, say, overuse or being eligible for Medicaid and using it when they should not be. Now, if we're thinking about cost in Medicaid, sometimes it can be very difficult to separate outliers. So like really high utilizers of Medicaid, and separating that from actual fraud. So because someone who might have had an extensive amount of ER visits, for example, something else could be a problem that may or may not indeed be fraud. That would require a closer inspection. Now, as far as like the equipping states for that, states are also very different, so autonomous in how they operate Medicaid, but they are also very different in how much they invest in terms of Medicaid staffing and capacity. So many states are very limited in terms of their own ability uh, to detect fraud, even if they have all the Medicaid claims data. So these are all things to be aware of, and in going forward with having these discussions with your partners and states around Medicaid, these are questions that you can ask, like what types of resources do they invest in their Medicaid operations.
Sure. Marvin, I want you to weigh in here as well, and then I'll kick it over to Truman for my next question.
Yeah, Brother Benitez kind of covered a lot of it, man. It's a lot. It's just another barrier for people to have the healthcare that they need. If you look at some of the projections of how much work requirements are going to quote unquote save the system, is $120 billion. It is because there's a disenrollment of people, right? Like most of the folks are either working, as Brother Benitez had mentioned, are unaware that they have to attest to working, or their eligibility window, they are not aware that they had to at any given point go back and kind of prove that they're working, right? The attestation issue that I mentioned earlier. And I got to think about working class people, right? So my mom was a home health aide growing up. We had Medicaid. My mom was a wage worker. I can't imagine my mom being able to take a day or half a day, right? Because we all know that it takes a while to go to the Medicaid office and go through that process. She would have lost likely her job, but if not her job, the $120 that she earned in 6 hours, because she had to go and prove that she needed the health care that we all know that she needs. And so it is that, right? It is another attempt to prevent people from having the care that they need. The idea that you need to prove that you work to get the care that you need, which in reality, you need to be healthy to then work.
Exactly.
To me, is one of those things that, it smacks in the face of a reality, but it's something that is imposed for the very same reason that we talked about, which is to bring people to being as healthy as they can.
Absolutely.
So out of all the proposals that I've seen there, this is the proposal that has the most legs and the most potential to pass through the Senate and likely the House and be signed by the president. And again, before I turn over to Brother Warren, this is exactly what we are seeing as a manifestation of the base that people are having, and it's concerning. And when people say, "Hey, work requirements," it sounds good, but we have to ask a secondary question: what are the impacts?
Exactly.
Who are you trying to target when you do these policies? Because that will give you much more of an insight as to what's happening, as opposed to just a simple talking.
Absolutely. That's a great segue into my next question for Brother Warren. So I also was on Medicaid at some point in my life as well, right? So like I've lived it, and I know family who also were on Medicaid. So Brother Warren, as someone who was on the ground, can you share? Because there was something about the power of the story, or the power of the narrative. Can you talk a little bit about what Black men have been sharing with you about their challenges, their ways in which they feel that the system can be either disrupted, dismantled, or transformed? Can you share kind of from your vantage point what you've been hearing, so that we can kind of humanize this and make it real and relevant for Black people writ large, but definitely Black men?
And honestly, the Black men that I've talked to, they feel like it's not for them. They feel like that they don't have any hope for them. They feel like it's mainly for women and children that even though they may meet the requirements, they may have the requirements that that they can sign up for this this life-changing health program that can help them get the preventable treatment, the screenings they need, that but they somehow always get disqualified because of the work requirements of the things of that nature that prevents them from those treatments. And these are life changing treatments, or they early detection from prostate cancer that may take their lives away. They can cancers, prostate cancer, get prostate cancer if it's not detected early, metastasize or spreads into other parts of their body. But if we detect it earlier enough, we could take care of it before then. So if we have Medicaid for them and they're treated early enough, and they find them a PCP, and they found one that can help them with this particular condition, then they can have hope. That's what, as alpha men, we want to give hope and be beacons in our community and allow them to have this hope that they need to allow them to say they'll be there for their family, be there for their children, and be there for their loved ones. So we want to make sure that that's what I personally seen. I've seen them in my counseling window. I've seen them in my community. I've seen them in the grocery store when I've talked to them when they say, "Oh, that's my pharmacist," and I've seen it. I've seen it firsthand. So I've experienced it. And as far as what we can do as our local policymakers that we know, and we're going to Alpha Day at the capitals. Most of the districts have it, and we can talk to those, and we mostly talk about things that are things we sometimes we may miss the healthcare piece, but healthcare is important. And I'm glad that we have a surgeon general now, and we have deputy surgeon generals that we can be advocates for healthcare. Because if we're not here healthy enough, all the other doesn't really matter. So so we want to make sure that we're here doing the work of Alpha, and we're able to be here to do the work of Alpha. So
Sure. Absolutely. Thank you so much. So as we kind of round the corner and kind of shift into some more of the solutions aspect of our conversation, I do want to hold space for each of you to share your thoughts, advice for, share some actionable tactics and strategies, um, thoughts that you want to really ensure that we can drive home for our audience before I kind of yield the floor to Brother Dr. Sterling. So I'll start with Brother Warren.
actionable items, I would say education. The one of the biggest things, I'm a big proponent of wellness. Kate, especially if you can be advocates of things like flu shots, prostate screenings, colon cancer screenings, prostate exams. Be a big advocate of educating. These are low cost screenings, especially if patients do have Medicaid. These are actually well, if it's Medicaid, or if they have, even if they have commercial insurance, these are sometimes more free because they're preventive care. Preventive healthcare is usually free, or they're low cost, and in the long run, studies have shown if you use early detection, this allows them to say that the money that we're looking at as far as the budget cuts, these are the things that they're looking at. They're saying, well, we're not using the preventative care, let's use the preventative healthcare to cut this the worry about the prevention of the fraud and the waste and the abuse. If we use this, we educate the members of this the recipients of Medicaid and things of that nature. So I will be a big promoter. My action items, educating and having them understand the importance of the action items of wellness and things of that nature.
Absolutely. Thank you so much. Brother Dr. Benitez, please chime in here.
Sure. So all of us are differently engaged in some aspect of Medicaid policy. One thing I would advocate that people can do is follow along with the discussions and the status of Medicaid in your own state. For example, I'm in Kentucky, which Kentucky expanded Medicaid in 2014. So it was the first, Kentucky and Arkansas were the only southern states at the time to expand Medicaid. So we're among the first to do so. So Kentucky performed extremely well under Medicaid expansion under the Affordable Care Act, also known as Obamacare. Follow along with what your state is doing. For example, Kentucky just recently the state legislature moved forward a bill that would implement work requirements in Kentucky's Medicaid program. As you become more interested in Medicaid policy going forward, a few resources to aid in your own discussions would be from KFF and KFF Health News. You can follow along with the Urban Institute, the State Health Access and Data Assistance Center, which is at the University of Minnesota, the Commonwealth Fund, but most importantly, follow what's going on in your own state or anywhere where you might have family members who use Medicaid to maintain access to healthcare and get the care that they need.
Absolutely. Brother Figueroa.
There's a penalty to coming in late, right? I think most of the brothers already mentioned what I was going to highlight. So at the risk of sounding repetitive, there's a couple of things that I want to underscore. It is important to know the Medicaid services in your state, and it's also important to know what the name of your Medicaid program is within your state, so you can know what's exactly at stake. It's important to you to engage at every level. So engage the state level, right? Because Medicaid is a state partnership with the federal government. Engage your state legislator. They have a lot of control, a lot of power over Medicaid. Your governor has a lot of power over Medicaid and what happens and what doesn't. And then your federal legislator, your congressperson or your senator. Having worked in a Senate office twice now, what doesn't get called, so if you're not calling about Medicaid, you're not writing about Medicaid, you're not meeting about Medicaid in a Senate office or a congressional office, it means that it doesn't matter to you, right? That is what the interpretation is when you don't engage on a particular issue. So make sure that you're engaging in the issue itself so that folks know that there's an issue that's important to you and you are a Medicaid or a healthcare voter, right? Because that's the consequence of voting against healthcare. The other part, and I'll go to the other side of the ledger, if you allow me, good brother, is making for brothers, let's make sure we use our healthcare. Yeah. Right. Let's make sure that we are going in for that check-in, that we are going in for that preventative care. You know, talk to your line brothers. You know, we know how to do all the other stuff with the brothers, but sometimes we don't know to be like, hey, good brother, did you go to the doctor this year? And if not, I want you to make that appointment. Right. And that is the other component of this. We can't talk about bad outcomes for Black men when Black men are not checking on each other to ensure that they are using the services available to them. So let's make sure that we are recommitting ourselves to those check-ins and those questions of each other before we go out there and require it from other people.
Sure, that's a fantastic point. And, you know, I'll share, you know, on my end. So I'm real big into self-care and soul care. So I see a Black psychologist at least once a month, maybe twice a month on a regular basis for my own maintenance and self-care. So I think being vulnerable and transparent about seeking support and is absolutely critical for giving other brothers and people permission to feel like they can also seek help. And while this particular webinar isn't focused on the challenge of medical help seeking, which is an entire different conversation that we can have on another webinar, I will just hold space to at least, to your point, Marvin, like self-care and soul care. I went to get a second routine colonoscopy 3 weeks ago, right? Just as a routine to make sure that I'm healthy, and you know, I'm real big on sharing my experiences and like, you know, because again, I found that when you are able to open up and share how you have been engaging with the healthcare system, and again, the engagement piece for Black men, that's a whole conversation right there as well. But I think, you know, being able to talk about how we want to encourage each other to take care of ourselves is critically important. There were a few questions that came in from the audience. I want to make sure that they get answered. Yes, there was one for Brother Dr. Benitez. Are you able to see the question there? I can read it. Yeah.
I can see the question. Thank you. So, all right. So to paraphrase from your question, let's see. So, yes. So being overrepresented in Medicaid. I guess to speak to if we were to move away from these types of social programs, let's think about what these social programs are for. These programs exist to fulfill a need that is not that does not exist elsewhere. So, for example, um, while I mentioned earlier that black households and black men especially are overrepresented in terms of poverty and especially every other adverse social outcome you can think of, we tend to be overrepresented there. Um, but then we gaining coverage over the life course or over say a life. So a child um, born gaining access to Medicaid compared to a child that would not have had access to any type of health insurance coverage is less likely to be in poverty as an adult. So, recognizing that these programs like Medicaid, even other social programs like unemployment insurance and SNAP and WIC, and they have some value that sometimes you're not going to see immediately, but you'll see over the course of life as it's moving people out of poverty and transitioning into a better phase of life. Um, to comment to Dr. Enya, a lot of people are increasingly benefiting from access to behavioral health services that they can only access via Medicaid because they don't have access to other sources of health insurance coverage. And we're starting to see this a lot, especially with people who were justice involved or people who might have been transitioning out of the prison systems, for example. So people, many states are starting to experiment with allowing coverage for justice involved persons when many states used to not have allowed for this. It's actually led to reductions in recidivism because people are able to get the behavioral health services and the mental health services that they need and other healthcare that they need that provide substantial value in helping them to stay out or not go back to prison. And then I can't harp on this enough. While being overrepresented in poverty, um, overrepresented in Medicaid, um, substantially underrepresented in jobs that offer health insurance coverage.
Mhm.
So, if more Black households or Black persons had jobs that offered health insurance coverage benefits, then that would actually supplant some of the need for being able to access another health insurance program like Medicaid, or even being able to earn enough to afford a private health insurance program through the state's individual health insurance markets. So, kind of, I don't think it's about moving away from these programs completely, but understanding their value to society and actually who is benefiting from them and how people use them.
If I can add one thing, brother,
Yeah,
is so behavioral health is a required covered service
yeah.
in Medicaid. The
Mhm.
scope and extent is something that a governor or a state legislator determines.
Yes, my apologies.
No, no, you didn't make
Yes,
you
yes,
didn't make
yes,
the
yes,
mistake at
yes,
all.
yes,
I
yes,
just wanted to
yes,
emphasize that. And
yes.
if the goal is to get brothers engaged, is again, there are things within the requirements that are required, but are things that are optional and are policy decisions.
Mhm.
We should be engaged in those policy decisions to drive home the point. These are
Right,
services that we want and demand in our communities.
right.
Absolutely. All politics is local. Um, this is, and I say this all the time. Um, if you're not at the table, you're on the menu. And so I think for us, as leaders and as advocates, we are tasked with being, first of all, servants of all, and really kind of living out our aims and our motto. And as we kind of close out, I do want to just kind of, you know, share some quotes here to say that for me, with my family, our theme this year is thrive. A healthy family is a wealthy family. And I also note that that when men are healthy, families are strong. And when families are strong, our communities thrive. And so, with that being said, I'm going to yield the floor to Dr. Sterling. I want to thank the brothers here assembled for your time, your expertise, your thoughts, your wisdom, and I look forward to future conversations of this nature. So, thank you, thank you, thank you. Brother Dr. Sterling, you have the floor.
Thank you, good brothers. Fantastic job as always, and we look forward to having you on additional webinars. I want to reframe a lot of what has been discussed in this conversation because we're operating in a set of assumptions that don't match the current political reality. We assume that healthcare is a right. In fact, every civilized nation on the face of the earth actually believes that part of the societal construct is the delivery of health, education, some form of welfare, and police services. So we enter into the conversation from the left with that framework. That is something that came to fruition in America, obviously, with the implementation of Medicare and Medicaid, but that is not something that is universally accepted. And I'll begin this conversation by pointing out that from the right, elections have consequences. And I want to explain to you and the guys that I hope you'll take home with you something to think about, because these aren't conversations that are frequented in our community, but this astute group of public health professionals should be aware of this conversation. And I just want to make sure that this part of the conversation is enhanced to the extent to which it has not been. The mantra that is governing, let's put politics aside and let's actually just look at what a rightward view of healthcare delivery actually would look like. As I mentioned, elections have consequences, and I told you the whole healthcare is a right, universal healthcare should be an offering construct is really a leftward consideration around the world. We need to understand that. The right really ran on and is seeking to implement a mantra that government is too big. Government in all forms need to be reduced. In my introductory comments, I actually mentioned to you, the United States spends more on healthcare than any other nation on the face of the earth. We literally spend more than 20% of our gross domestic product on healthcare. No other nation spends more than 12%. We spend over $4.8 trillion a year in healthcare. Okay, so in doing that, we produce pretty horrible outcomes. When these things have been measured, the United States typically comes in the mid to low 30s in terms of ranking of healthcare systems. So there's an argument just based on outcomes that there is inefficiencies. Let's not call it waste quite yet in these conversations. And I'm bringing that up to offer up this point. If you were inclined to cut, and by the way, because this is 20% of the US government's expenditures, if you're going to look to reduce government and cut anything, at some point in time, you're going to get around to a conversation where you are cutting healthcare. Okay, because there is a lot of money. Now, what we would be concerned about, and this is getting to the purpose of this particular webinar, what we should be concerned about is not necessarily the absolute expenditures of money, but the effectiveness of that spend and the production of healthcare outcomes. See, I'm here to tell you as a physician, knowing that HMOs came about in the 70s because physicians walked away from managing the healthcare system in this country, that if you took a look around in your city and around the country, you'll actually see that the largest buildings in your city and around the country are insurance companies. So we always want to blame people who want an extra prescription or physicians who want to practice and offer their patients a little something extra and define that as waste and fraud. The money in the system that really could be gone after is the percentage of money that is being made in profit. One of the biggest arguments from the right eternally in terms of not having universal health care has always been that it would wreck the economy. There's so many economic engines that are stimulated. And that actually is a correct point. During the COVID pandemic, it was healthcare that kept the economy afloat. But when there is this amount of profit, okay, more than 50%, almost 53% of the money that is spent nationally on Medicaid is actually money that is being given to the managed care organizations, to insurance companies that are managing this money. The top 5 managed care organizations in the United States are all on the Fortune 500. Why did Jesse James rob banks? That's where the money is. So to be looking at citizens putting workplace requirements and means testing and other such things instead of to the detriment of not having any conversations about the overwhelming amount of money in the system that really is just a redistribution of money from the lower class citizens that are receiving services to the profit margins of entities that have to make more money quarter after quarter in order to satisfy their stakeholders is a bit disingenuous. So when we define waste, let's talk about that in terms of inefficiency. Now, okay, so here we go. Now let's talk about what our job is, folks. Our job in our communities and in our families is to protect healthcare outcomes, to reduce healthcare disparities. African American men save Native Americans, save natives, okay? Have the demographics with the worst healthcare outcomes in the entirety of the United States. We have work to do both on ourselves and on the system. We have to protect healthcare outcomes in our community and reduce disparities. How do we do that? Well, let's look internally first. We must engage in better, healthier habits. We must embrace health prevention and health promotion. We are the stewards of our own healthcare. We've got this. We have to get rid of the post-surgical eating habits that now define us. We have to stop embracing obesity that sets 70% of this population as some type of fashion statement. You know, back in the motherland, by the way, meat was only consumed when it was roasted on an open fire as part of a celebration. We lived off of the land. Our ancestors, our forefathers were very much more healthy than we are. We can get back to that, okay? Now, as I'm gonna finish where I start, guys, elections have consequences. If you are at all concerned about how we got to this point to where you and your families are worried about $880 million being extracted from Medicare and Medicaid, you need to become involved locally, in your states, and nationally. You know, we typically have, as a community, haven't been one issue voters, but I'm here to tell you, if there's one issue that might be of importance to you with the healthcare disparities and the inferior healthcare outcomes exist, it might want to be healthcare. And that's where I'm going to leave you this evening. I want to thank again the panel for joining us, and I want to welcome you again next week. We'll have a special edition of the Surgeon General Health Initiative. Come join us. It'll be another fascinating topic with another fascinating panel. Again, thank you to Brother Lucia Metellus, our General President, and the Deputy Surgeon General, and all the members of the Surgeon General Initiative who participate in webinars like this and strive to improve health for ourselves, our families, our communities, and the nation in general. Thank you, God bless, and good night.
Thank you.